So you tell me, or can I start talking?
That's a nice signal.
Okay, so Dr. Daha, you can start.
Okay, good evening, good afternoon, good morning, everybody, depending on where you're tuning in from. This is Safwan Taha. I'm the governor of the UAE chapter of the American College of Surgeons, and this is the second in our series of webinars that is sponsored by ACSUAE. Many thanks to them for their generous support to bring those webinars to life. Today, it's both a very nice topic and a great collection group of authoritative speakers and writers and expert surgeons who are going to talk about today or share their experience with us today about a quite intriguing subject, and that is revisional bariatric surgery. I mean, this is the really thorn in the side of most bariatric surgeons when it comes to management of revisions. So I'm just presenting our speakers today alphabetically by the first name. It's a pleasure really having them, not only because they're only authoritative, but all of them are a very close friend of mine, and it's a very, very big honor for me to moderate this session. So the first, alphabetically, our first speaker is Dr. Abdurrahman Nimeri. He's Associate Professor and Chief Bariatric Surgery. He's Director at Atrium Health Weight Management, Carolinas Medical Center. He's Director of Carolinas Bariatric Minimal Invasive Surgery Fellowship. He was Secretary and Treasurer of ACSUAE 2019 and past President of ACSUAE and Pan-Arab Society of Metabolic and Bariatric Surgery. He's also Associate Editor at Journal Obesity. Welcome, Dr. Abdurrahman, to the webinar, and thank you very much for joining us. The second speaker alphabetically is Dr. Ali Khammas. Dr. Ali is head of the General Surgery Department in Rashid Hospital, Dubai. He's the president of the Emirates Society of Metabolic and Bariatric Surgery, and he is the president-elect of ACSUAE. The third speaker, alphabetically again, is Dr. Antonio Torres, Professor of Surgery, President of ACSUAE 2011-2012, Chairman of ACSUAE's Board of Trustees 2015-2019, Governor, I hope I'm right, Antonio, Capitolo Español del American College of Surgeons, which means the chapter, more or less. Thank you. And he's Chief General Surgery Service, Department of Surgery, Complutense University Madrid Hospital Clínico San Carlos, Madrid, Spain. And we have also with us, unfortunately, he's still in the OR for an emergency. Hopefully he can join us later. Professor Khalid Jaudet, the Chief of Surgery, Ain Shams School of Medicine, President ACSUAE Chapter, Associate and Advisor Editor of Obesity Surgery. And last but not least, my dear friend, Dr. Thomas Regula, is Associate Professor of Surgery, Case Western Reserve University School of Medicine, Cleveland, Ohio, USA. He's Professor of Surgery. Tom, it's difficult for me, but I hope it's right. Jagiellonian University School of Medicine, Krakow, Poland. Yes. And of course, probably all of you know him better than those as the president and founder of the very big league now, International Bariatric Club. I welcome on the behalf of all the audience, I welcome you, my esteemed speakers, to the webinar. And we again start with alphabetically. Abdurrahman is arriving home. Thank you very much for taking the time to join us despite that. And we will start with Dr. Ali Khammas. And Ali is going to talk to us about a revision of sleeve gastrectomy to one anastomosis gastric bypass. Dr. Ali, the screen is yours.
Thank you, Dr. Safwan, for this presentation. I actually did not find myself in your words, but nevertheless, the sleeve gastrectomy to one anastomosis gastric bypass, something that has been going on for quite some time now, and there is good evidence that it is a good bariatric option for failed weight loss or for weight regain after sleeve gastrectomy. I am actually not going to bother you about too much of the science behind it, but rather I will do on the technical aspect of doing the surgery, because I don't think that this is the only surgery in our armamentarium, but it is one one of the good ones. So let me share my screen. You see what I see in the screen, guys?
Not shared yet.
Not shared yet. Okay. I don't know. Let's go and share screen again. I'm still in the meeting because it says leave the meeting. Cancel. Screen.
Yes, now you're talking. You're there.
My screen is there?
Yes.
Okay, so what do we do when you need to pick your patient? I mean, we know that in 5 years period, about 10% of the patient undergoing sleeve gastrectomy are going to regain weight. If we follow them for 10 years, we will see about 22% gaining weight, and that's international figures. But locally, we see, I mean in the Gulf region, and I don't know about the rest of the Arab world, the numbers are higher. We see something close to 20% at 5 years. So we used to do in 2013, 14, and 15 revision of sleeve gastrectomy into one anastomosis gastric bypass for another reason, that is GERD. But we actually stopped doing that because in our series and Dr. Osama Taha's series, we found that even in the primary, in these revisions, a good amount of them, nearly 30%, develop GERD post-surgery. I mean, if you convert a sleeve to an anastomosis gastric bypass without for GERD, it does not work. And if you convert them for without picking them, I mean, just not asking the patient if they have GERD or not, you will end up with this big number of GERD patients. So we actually, if the patient have any signs, any symptoms of GERD or any signs of GERD in preoperative endoscopy, we actually opt to do a Roux-en-Y gastric bypass with a long limb, a long biliary limb. Technicalities about this surgery. This is pretty easy surgery because you see that the liver even has left itself without the liver retractor. So one thing that you need to do first is to release the tube from the omentum all the way to the angle of Hess. And many times when you do that, you will see that the previous surgeon have actually not cut one or two of the short gastric vessels. That's not so uncommon encounter. So you need to be ready for that. So we always do release the omentum from the tube all the way to the angle of Hess. Another aspect of the surgery here is that you need to add a restrictive part into the operation. You need to make this tube somehow narrower, either with the staplers, or if you see that the previous sleeve is actually so good that you cannot put a stapler, then you can just plicate it. Sometimes the sleeved stomach is so huge, it's almost the size of normal stomach. And I warn surgeons of thinking that doing a standard mini on that, leaving the stomach behind, I mean, leaving a remnant stomach like they do in primary surgeries, because those remnant stomach has been cut off the blood supply from the previous surgery, or from the lateral side, from the omental part, and now you cut them off from the other side, so you will end up in perforation even if the stomach looks pink. And then when we divide the stomach like I'm doing here, you have two choices. One, dividing in the standard way like I'm doing in this surgery. If it is difficult, you can come from the other side also, I mean from the lateral side to attack the tube from the other side. If you can leave a small part like I did here, it's good. And then you put the calibration tube and you insert the stapler and see if you have a space to put a stapler. This is the trick I use. So I leave that small part at the lateral side, and then I put the stapler and I ask the anesthetist to see if there is a space for the calibration tube, and I use a 40 French calibration tube. And then I start sleeving the pouch in order to have a restrictive power into the new surgery. I believe that bariatric surgery without a restrictive component is doomed to fail. And then I just continue. I usually use purple loads. I rarely needed to use a higher stapler. Sometimes you need that if it is post band, because there's so much adhesion on this side, but rarely on sleeves. Like you see here, I'm not so happy about the lateral side, so I dissect more, and then it just releases. And then now I'll do something stupid. You will see, and I'm trying to remember why I did that. This operation is done in February. I don't know why I did that. I actually cut this sort of what I thought was adhesions. I've done that in a patient previously, and she leaked. I'm not saying that this is very dangerous, but I am saying that it's really unnecessary to do this. I think here I'm trying to see if there is more stomach to be pulled laterally or not. And apparently there is none. And I checked here that the staple line is going all the way. And then the rest of the operation is just removing this small part. One might say this is a very tiny part. What value does it add into that pouch? It actually does add a lot of value, I think. And then the rest of the operation is just standard one anastomosis gastric bypass. I usually do 150 biliary lymph because more than one study have shown that increasing the lymph above 150 does not add value into weight loss. It just adds some malabsorptive, malabsorptive power rather than weight loss. And we don't need that. And then the other thing, if someone has failed a primary operation, they're definitely a high risk of failing the second operation. So you give yourself a chance for those patients, whatever the percentages, if it's 20 or 30% after 5-6 years, and you have 150 lymph, to see if you can help the patient if they regain weight after this surgery also. Definitely a third operation has very much less power. I usually fire 30 stapler for the anastomosis. Previously, I used 45, but then I started to see failures of my MGBs that was done in 2013 and 14 and 15, where I used the 45. So now all the MGBs, revisional or primary, all anastomosis are 30 staplers. There's one interesting study by Mohit Bandari that he have not seen any weight loss after one anastomosis gastric bypass for failed sleeve. He actually writes that the weight loss after sleeve, before they started gaining weight, the NADIR, NADIR, was actually higher than what they achieved after this operation. But he's probably the only one that reported this, and I could not figure out how come he reached his data is like that. All the data I looked up was actually different, of course, from author to author and different follow-up periods, but they are showing that this surgery is safe. This surgery gives you the result in weight loss that you intend to have, and it's good, and it's very easy surgery. But I would rather not to do it for any patient with GERD. I'm actually done with my talk.
Thank you very much, Ali, for the nice presentation remarks and sticking to the time too. We have 5 minutes for questions. The audience can ask their questions on the chat box or sign below, and we'll communicate them to the speakers. But I have one question, Dr. Ali, being having one of the largest series, if not the largest, in the Emirates with one anastomosis gastric bypass. There's been a long debate about how long the pouch is. I mean, not how narrow. I think more or less now, apart from quite a few % of surgeons, everybody agrees that you need to have some restriction. But how long is your pouch? What's your argument about it? Is it like people say it has to be more than 25 centimeters or 20? And what's the argument?
I really don't know about this, Safwan. My pouches are usually 360 staplers. That's almost 18 centimeter. But you actually, when you after you fire the last one and you measure it again, it's something between 12 and 15. And this is also, I think I've listened to Mohit Bandari once with the Phoebe. They're saying that it should not be less than 12, and I definitely agree with that. But going beyond that, I don't know. You know that the closer the antrum you are, the more ulcerogenic your anastomosis is going to be. So I'll stick to the body of the stomach rather than going below that.
Thank you very much. But I posted a video of how I do IGB online like last year, and I do just like you. I mean, it's around 360 staplers, and I got a lot of very polite criticism that my pouch was less than 20 centimeters. I don't know, Antonio, Tom, if you have any remarks here about how long is the pouch in OEGB?
Well, we don't perform in a systematic way, one anastomosis gastric bypass, We prefer to perform the anastomosis, below the pylori, performing the Sadish procedure. Because we don't consider, to perform anastomosis, you do the antrum and the bowel. But, regarding, the experience of, Ali had, you know, we have to follow their comments on that. You know, I would prefer to perform an anastomosis between the duodenum and the small bowel. You know, I think it's more physiological to do that. But anyway, you know, I think anyway there is some ulcerogenic approach. You perform an anastomosis between the stomach and the small bowel, and but another issue we need to avoid, you know, the biliary reflux. You know, it's going to be another option. You know, in our experience when we perform, you know, a study I'll show you later on comparing one anastomosis gastric bypass and a SADIS procedure in this scenario after failed sleeve. You know, I think, you know, the biliary reflux is going to be a very important the birth effect, you know, of the patients.
Yeah, of course, point very well taken from the inventor of SADI, and we'll listen to your expert comments shortly. Any comments from Abdurrahman, Tom, about the length of the pouch, if you have any?
Let me comment shortly. I don't do mini gastric bypasses at all, but I learned from you, my dear colleagues, the mini gastric bypass experts, and I actually modify my regular gastric bypass, and I do very long pouch for Roux-en-Y gastric bypass, and patients like it because they function quite well. They eat pretty much in a normal way. They don't have the terrible dumping or nausea or nothing. I even had one gastric bypass yesterday. I did my private clinic here in Poland, and the patient specifically asked me, please do the long pouch because my colleague had a short mini pouch and he has terrible life. So I appreciate long pouch. Small fundus, but long pouch works very well for Roux-en-Y gastric bypass.
Yeah, actually, I've welcome Abu Ali. Ahlan wa sahlan. Now we can see you.
Thank you.
And I'd like to have your comment about this thing about, you know, I've noticed lately in the past couple of years, there's a shift of, although it's not Ali's topic, but since Tom raised it, a shift of towards lengthening the pouch of the Roux-en-Y gastric bypass. You know, we used to say 2.53 centimeters, and now I'm seeing prominent surgeons doing like 10 centimeters, 8 centimeters. Any comments?
Sure. So initially, I agree with both Antonio and Tom that if someone has a sleeve, if they have reflux, we'll do a Roux-en-Y. If they have no reflux, high BMI, we'll usually do either a CD or a DS. In regards to the long pouch, there is actually a randomized trial that I will show you with short-term outcomes, comparing a short and a long pouch, showing a little bit of a better weight loss in the long pouch. But my concern is the marginal ulcer rate, because the Swedes have shown that any pouch that is larger than making 3 cartridges has a higher marginal ulcer rate. So every 10 millimeter increases the marginal ulcer rate at 1 year by 14%. So my concern is the marginal ulcer.
Thank you very much. Thanks a lot, Ali and the panel. So again, we go alphabetically. Then the next speaker will be Abdurrahman now. And Abdurrahman will be speaking about a very interesting subject that I had the pleasure to listen to when he was with us here in Abu Dhabi. And it's his vision of the best way of doing a revision of the gastric bypass through measuring the biliary and alimentary limbs. And Abu Ali is arranging. Okay, we see you again.
All right, perfect. So let me just put my my presentation on.
So he's the guy, Dr. Abdurrahman is going to talk to us about the optimal way of getting the best out of revision and Roux-en-Y gastric bypass through a principle in measuring the alimentary and the biliary limbs. The screen is yours, Dr. Abdurrahman.
Thank you again, Professor Safwan, for the opportunity. So this is my disclosure slide. It has no relevance to the presentation. I'm going to try to cover these 5 areas in the next 15 minutes. So how are Roux-en-Y and one anastomosis gastric bypass similar Is the root limb important for weight loss? Is the BP limb important for weight loss? Can you make the BP limb too long? And what's the optimal total elementary limb length if you're doing a revision of a patient to a Roux-en-Y gastric bypass? I think we have to agree first that revision Roux-en-Y gastric bypass has lower weight loss than primary Roux-en-Y gastric bypass. And this is at least one study with a matched analysis showing that when you're revising someone from a band or a sleeve, their outcomes in Roux-en-Y are not as good as a primary case. In addition, I think one of the most important things to realize that as a surgeon, you are making an assumption about the small bowel length whenever you're doing any intestinal procedure, unless you measure from the ileocecal valve. So this is a study by Roberto Tacchino showing that the small bowel length could be from 350 to 1050. And this assumption is an assumption you have to test if you make the biliopancreatic limb long. And I'm going to come back to this through the presentation. I think initially, I just want to set the stage by making sure that the audience is aware that Roux-en-Y gastric bypass, BPD, and DS are all forms of Roux-en-Y gastric bypass. And what makes them different is the size of the pouch, the length of the biliopancreatic limb, and something we will call TAL, or total elementary limb length, which is the roux limb and common channel. And I think this is an important point to have in the back of your mind. I think second, it's important to know that there is nothing in common between Roux-en-Y and one anastomosis gastric bypasses except their name gastric bypass. They have different size pouches, they have different length of the BP limb, their total elementary limb length is very variable. So their outcomes are not similar, and it is no surprise. And I think the final point that's important to keep in mind throughout the talk is if you do a looped procedure, unless you measure from the ileocecal valve, like in SADI, you need to make sure that you know what is the common channel length. And in this case, it will be the total elementary limb length, as we will allude to. It's interesting to know that we have come a full circle. All the surgeries we do started in a looped fashion. BPD started in a looped fashion on the left. Roux-en-Y started in a looped fashion on the right. They became both Roux-en-Y configuration, and now they're coming back to a looped fashion again. So Roux-en-Y is becoming one anastomosis, and DS is becoming SADI. So history really has come a full circle. So is the roux limb important? The short answer is no. And I'll show you 3 studies that have shown that the roux limb does not matter, and 1 study that shows that maybe it matters. This is the initial study from '92 by Bob Brolin, comparing 75 to 150 roux limb. Initial better weight loss, but at 4 years, there is no statistical significant difference. Similarly, the group from New York, led by Michel Gagné and Alphonse Pomp, compared a short with a long roux limb at 1 year, showing no significant difference. I think the most definitive study is this study from Norway that looked at a roux limb of 150 with a BP limb that's short compared to a common channel of 150, and the rest is roux limb. And what they found was that the weight loss at 2 years is the same, but the risk of complications is lower when the roux limb is short and much higher when the common channel is short. And this is liver failure, protein calorie malnutrition, and we will come to this throughout the talk. And I would be remiss if I did not mention this Dutch trial. The Ducati trial did a very similar configuration to this study from Norway. And at 1 year, they showed no difference. At 3 years, they showed a very small 3% total weight loss difference between them. I think it's important to mention that this study still doesn't have long-term follow-up, and it will be interesting to see how patients do long-term. Again, they made either a roux limb that was 150 or a common channel that was 100 centimeters. So really, the roux limb, the literature shows that it does not make a big difference, and you just need to make sure it's long enough so you don't get bile reflux. Now, how about the biliopancreatic limb? I think this is one of the most definitive studies from Iceland and Norway. 187 patients that were randomized to either a short BP limb of 60 centimeters or a long BP limb of 200. And it's important to note that when they lengthen the BP limb, they shorten the Roux limb. And I think this is an important concept for surgeons who do Roux-en-Y gastric bypass. The more you lengthen the BP limb more than a meter, you need to shorten the Roux limb so as not to exclude too much small intestine. And what they found was the longer the BP limb, the more weight loss, as you can see in blue, in both obese and super obese patients, but it comes at the expense of higher nutritional deficiencies, mostly vitamin D deficiency, hyperparathyroidism, iron deficiency, and low hemoglobin. And I think there are two important studies from the Netherlands, both randomized from Fritz Berend's group. This is the first one, it's called the Elegance trial. They randomized patients to either a short BP limb of 75 centimeters or a long BP limb of 150, and in each they alternated the Roux limb. So if the BP limb is 150, the Roux limb is 75, or vice versa. And this is what we do for any patient that we operate on with a BMI over 50. What they found was that the longer BP limb has better weight loss, but this trial has some loss to follow up at around 4 years. So the weight loss difference was lost after the second year once they lost patients for follow-up. Their second trial is called the Redo Elegance trial. Very similar design. The only difference is it was in patients who had a band before, so the band was removed and a gastric bypass Roux-en-Y was done. And in this trial, they did not have loss for follow-up. Their follow-up rate was 95%. And the difference in weight loss was maintained up to 4 years in the study. Now, I'll be remiss if I do not mention a randomized trial by Rui Tovar from Spain, a large number of patients, 253 in each group, 245 and 53, where they had a BP limb of 70 centimeters versus 120, and they kept the Roux limb constant. And this study showed that there's actually no difference in terms of weight loss from the BP limb. My only concern is the senior author in this study had a major randomized trial retracted for concerns by IFSO. So I'm not sure what to make of it, but it's the only trial I know of that showed no difference in BP limb. But there is a systematic review that has looked at 13 articles that showed that the longer you BP limb, the more weight loss you will have. And the mechanism by this happens could be because of a higher level of bile acids. So this is a small trial that compared sleeve, Roux-en-Y, and one anastomosis. Again, best weight loss in one anastomosis, the longest BP limb, least with sleeve, no BP limb, and Roux-en-Y is in the middle. But if you look at the systemic bile acids, it kind of matches the weight loss and the length of the BP limb. So it does appear that a longer BP limb has something to do with bile acids, not only distal delivery of nutrients. Now, can you make the BP limb too long? And the short answer is absolutely. So if you look at the Omega trial, the surgeons who designed the Omega trial were one anastomosis gastric bypass surgeons. So they thought if you exclude 200 centimeters in each group, you should have similar amount of nutritional deficiencies. Why? Because you're randomizing the study. So they made the Roux-en-Y 150 of Roux limb and 50 of BP limb, and they excluded 200 centimeters from the one anastomosis. But the one thing we know now is when you exclude 200 centimeters in one anastomosis, if you keep the small bowel length constant, you end up with a shorter common channel or total elementary limb length. Why? Because you can still absorb food in the Roux limb. So in this trial, there was higher incidence of diarrhea, styrhea, and nutritional deficiencies in one anastomosis compared to Roux-en-Y, even though they excluded the same amount of bowel, and the weight loss was no different. This was a non-inferiority trial. And this is a study from ICUs showing that if you look at the ICU admissions for enteral nutrition and malnutrition and parenteral nutrition, 60% of them are because of one anastomosis, a very small percentage compared to the percentage from Roux-en-Y, sleeve, or band. And in previous studies where patients developed malnutrition after one anastomosis gastric bypass, a BP limb, like Dr. Ali Khammas mentioned, of 200 or more, had the highest incidence of nutritional deficiencies, and it some cases led to mortality. Now, we don't see a lot of severe protein count malnutrition or mortality after SAIDI, DS, and BPD. So why is it that a procedure like one anastomosis gastric bypass could lead to malnutrition, liver failure, and mortality? And I want to conclude my talk by describing why that happens. I think anybody who does intestinal surgery needs to know the total elementary limb length. It's basically in a Roux-Y configuration, the roux limb plus common channel, and in a looped configuration, it's the common channel. Why is this important? This is important for protein count malnutrition. So if the BP limb length gives you an idea about the robustness of weight loss, the total elementary limb length gives you an idea about malnutrition. And the SAIDI initially was described with 200 centimeters, and it had more nutritional deficiencies than 250, and 250 has more nutritional deficiencies than 300. So the total elementary limb length is important. And I want to take you through again, the assumption you make when you start a case that the small bowel length of your patient is 6 or 7 meters. And that assumption might not be correct. It could be as short as 350, could be as long as 1050. And let me take you through this table. Looks busy, but I'm gonna take you through it. So this table at the top has different procedures: BPD, DS, SAIDI, one anastomosis, DJB, and Roux-Y. And we're making one assumption, that the small bowel length is 600 centimeters. And I want you to focus on the a teal color row second from the bottom, the total elementary limb length. If you notice in BPD, DS, and SAIDI, they are constant and they're the same. So it is no surprise that the rates of nutritional deficiency is constant in the same, especially if you keep the stomach size the same. Now, if you look at one anastomosis, the procedure is less robust and less risk of nutritional deficiency than BPD, DS, and SAIDI. If you look at DJB, similar to one anastomosis. And if you look at Roux-Y, there's a very low incidence of developing protein count malnutrition because you have 550 of total elementary limb length, but maybe there's more weight regain. Now, let's test the assumption of the top left corner of 600 centimeters and make the table with a patient who has shorter bowel, 400 centimeters. Again, if you look at BPD, DS, and SAIDI, nothing has changed. The total elementary limb length is the same. So this patient, despite having short intestine, is not going to develop liver failure. But if you look at this same patient, if they had a one anastomosis and the surgeon did not measure the common channel, certainly the one anastomosis in this patient is more robust than BPD, DS, or SAIDI. DJB is even more robust, but the Roux-Y has the protection of the roux limb. And then finally, if you test the assumption one last time and you make the bowel length 800 centimeters, in BPD, DS, and SAIDI, the length is the same, but you can see now one anastomosis is a weaker procedure compared to them, and the weakest is Roux-Y. And this patient could have weight gain after Roux-Y, and you'll be saying that they just eat too much because their pouch is normal, their anastomosis is normal, they don't have a gastrogastric fistula, but they have too much small bowel to absorb a nutrient. So if you do looped procedures, you need to measure from the ileocecal valve, or if you measure from the ligament of Treitz, you need to make sure you have at least 300 to 400 centimeter of common channel behind you to represent the total elementary limb length. Now, there is something else in addition to the total elementary limb length, which is the point that Dr. Safwan presented earlier, the pouch size. So how big should your pouch be? The pouch should not be more than 3 cartridges. And the way we do that is based on what the Scandinavians described in 2016, looking at 14,000 patients from the Scandinavian obesity registry, one of my most favorite registries where there's great research to be done or being done every year. What they did is they had their surgeons measure how big is their pouch. So how do you measure? If you put one transverse 60 millimeter, that's 60, and then another 60 and a third 60. And they found that the mean length of the stapler for the pouch was 145, 145, a 60, and another 40. And what they found that this leads to a marginal ulcer of around 0.9%. And every increase by 10 millimeters increases the marginal ulcer rate by 14%. Now keep that in mind when we talk about the long pouch trial. How do we do it in our ORs? So this is how we do it. We start first by measuring from the lesser curvature, about 4 centimeters. We make a window between the neurovascular bundle, and then we use the stapler to about 45 to 50, roll it down to keep some more anterior stomach, and then 2 vertical cartridges to finish the pouch. Now, does this make a difference in addition to marginal ulcer? I think it does. I want to show you this very elegant study from Brazil that was published in 2018. They took 67 patients who had Roux-en-Y gastric bypass with 4-year follow-up and measured their pouch size by CT volumetry and measured their emptying of the pouch by scintigraphy. And what they found was the smaller pouch, less than 40 cubic centimeter, has the best emptying, has the best weight loss, less weight regain without an increase in dumping. And we've done a similar study with volumetry looking at marginal ulcer, and we could predict in our practice here in Charlotte, the patients who have a marginal ulcer have a larger pouch, and every 5 cubic centimeter increase doubles the rate of developing marginal ulcer after Roux-en-Y gastric bypass. And this is the trial I talked about earlier. This is a trial from the Netherlands, randomized controlled trial, 132 Roux-en-Y gastric bypass patients with a pouch length of 10 centimeters versus a pouch length of 5 centimeters. But there's only 2-year follow-up. And at 2-year follow-up, they found that the weight loss was similar, but the patients with the short pouch regained 3 kilograms. And I think what's important to note in this study is the PPI use was higher in the patients who had a long pouch, and they did not mention anything about marginal ulcer. So it remains to be seen whether this small difference is maintained long-term and whether the marginal ulcer rate will be higher. So to answer the question that Safwan asked me, how long do you make the BP limb in revision Roux-en-Y gastric bypass? You need to make sure that your total alimentary limb length is number D, not less than 400 centimeters, and that your common channel is not less than 200 centimeters. Why do I say that? So let me just show you the way distalization of Roux-en-Y gastric bypass was done. So in the top, when Sugarman made the common channel 50 centimeters, all the patients needed revision because of protein calorie malnutrition. When he made it 150, about 43.7% needed it. And you can see down the line, there is a sweet spot. You can see the study number 5 has 0% protein calorie malnutrition. So I just want to show you one last study, again from Norway, a retrospective study of 3 forms of distalization in 187 patients. So in the first group, the BP limb was 60, similar to the randomized trial that I showed you earlier. In the second group, it was 200. In the third group, was 200. But the difference between the second and third group is the common channel length. The common channel was 150 in group 2 and 200 in group 3. And let me just make sure you understand the difference in a schematic way. So on the left side of the screen, group 1, short BP limb in light green of 60 centimeter. Group 2 and 3 have the same BP limb length of 200 centimeter. But if you notice the common channel, it is shorter in group 2. So if you look at it, trying to measure in the right column, the total alimentary limb length, group 2 and 3 have the same total alimentary limb length and the same BP limb length. So you would think they should have the same weight loss and the same nutritional deficiencies, but there's a difference in their common channel, and that difference is important. So the weight loss was, as you expect, better in the longer BP limb length and shorter total alimentary limb length. However, if you look at the rate of nutritional deficiencies, it was the highest in the group with very short common channel. So the total alimentary limb length is not only about the whole length, but the area of the common channel is also important. So we have done a systematic review, and I'm going to conclude by showing you this systematic review that was published in SWORD last month, where we looked at all the patients who had distalization in revision Roux-en-Y gastric bypass. And we looked at the total alimentary limb length, 21 studies, and we found that the incidence of protein calorie malnutrition is highest when someone's total alimentary limb length is less than 400 centimeters and their common channel is less than 200 centimeters. So it's a balance. The longer you make the BP limb length, you could develop nutritional deficiencies if you don't test the assumption of the small bowel length. So to conclude, the length of the rule limb does not matter much, except for preventing reflux. And we have to await the Ducati trial long-term to see if their difference is maintained. The optimal length of the BP limb is unknown. We know the longer you make it, the more you'll have weight loss. But again, you have to test the assumption of the small bowel length you're assuming, unless you're measuring from the ileocecal valve. A longer BP limb leads to more weight loss, not through malnutrition, but through a complex mechanism that includes distal delivery of nutrients and elevation in the systemic bile acids and other things we don't understand yet. In revision room-wide gastric bypass, no matter how long you make the BP limb, avoid a total elementary limb length of less than 400 and a common channel of less than 200. No one knows exactly what the optimal length is. So I'm gonna stop there. And again, thank you very much for the invitation, and I'll be happy to answer any questions.
That was quite interesting, as always, Abdurrahman. Thank you very much. And it's amazing how manipulating the limbs can really affect the outcome. And then thank you very much for enlightening us about that. Any comments from our esteemed panel before we proceed to the next speaker?
Yeah, I like to, Taha, I like to comment, on the Abdurrahman presentation, going to be very important message to take home, regarding to be aware of, the length of the common channel when you are doing, some hypertrophy procedure. But my comment is regarding, you also must to take into account, that we are, having or putting together some restriction in the term when you are revisioning, the room-wide gastric bypass. So the component of restriction, you cannot forget that. You are adding some distalization in every way, but maintaining an important in inverted commas restriction. You cannot forget this, because you are adding two components, in terms of getting your aim of being more effective. So congratulate you. You're going to be very nice.
I totally agree, Antonio, and that's why I put the slides about the importance of the pouch size. If you have too large of a pouch in the room-wide gastric bypass, it does not empty. That's why roux stasis syndrome is basically a large pouch and a rulum attached to it, and it's known from general surgery. For the pouch to empty, it has to have a small capacity. And I think the other important thing is when you do procedures like BPD, DS, and SADI, you cannot make the stomach too small. Also, so you don't want to leave too much fundus in roux, but you don't want to do a sleeve with a 40 French bougie and do a SADI or DS 250 to 300. You will get in trouble so that's why when you do BPD, DS, and SADI, you need to use a 50 French bougie. You need to make sure the sleeve size is not the same sleeve size that you do when you do just sleeve gastrectomy.
Thank you very much, gentlemen. Again, I really enjoyed that presentation very much. Thank you, Abu Ali. So alphabetically, our next speaker will be Dr. Antonio Torres. And besides what I mentioned about Antonio's affiliations, of course, he's very well known for something that everybody is talking about all the time, he invented, and that is the SADI. And he's going to talk to us today, part of the theme of our webinar about SADI as a revisional procedure. And of course, he's the expert in that topic. Dr. Torres.
Okay, thank you, Professor Saban. First of all, I'd like to thank, in the meantime, I'm sharing my screen, to thank him and all the organization, for allowing me to share with you this outstanding webinar. My topic today is to talk about what is the role of SADI as a revisional surgery. Well, I think, This is my, disclosure regarding the procedure. We're increasing more and more revisional cases in our experience. We are now approximately 15% at present time. We do sleeve gastrectomy, we do Roux-en-Y gastric bypass, and we do SADI procedure. We don't perform in a routinary way one anastomosis gastric bypass. We perform this type procedure when we found some malrotation or some anatomical problem performing one of the other procedure. Okay, so regarding the revisional surgery or the role of SADIs after some previous procedure, we are going to focus mainly, of course, in the sleeve, and we will have some word regarding if some Roux-en-Y gastric fail. Is there any role for SADI procedure? Let's talk about that. So regarding, the sleeve gastrectomy, guys, this is the numbers of this, and yes, how we're going to be, as the time goes by, you're going to be the most performed procedure, around 60%. On the other hand, the Roux-en-Y, decreased from 36% in 2011 to now 17% in 2019. So focusing on the sleeve gastrectomy, I think when we have a well regain or some not losing enough weight, another issue, we have some problems, some physiological problem like GERD going to be another issue. We will deal with that later on. So what we can do is something happen after a sleeve gastrectomy. We can do, of course, at the beginning, nothing surgically. We can hope in thinking increasing the compliant enhanced program with the multidisciplinary approach, for 3-6 months, and to evaluate by the MDT. And now I think at present time, we have to take into account with the role of some medication, GLP-1 analogs or GIP plus GLP-1 analogs, going to be a very important role, in the future in terms of dealing with this topic. But what about if we have even to reoperate those patients after sleeve? Okay, there are two different issues. One is weight issues, or weight regain or not losing enough weight. And the other issue is the GERD, where I'm going to say now that the ideal procedure for treating those patients is going to be a Roux-en-Y gastric bypass. But regarding the first topic, going to be a very important debate regarding what to do. Banding the sleeve, re-sleeve, plicate, conversion DS, conversion to SADI, SASI, bipartition, and SASI. Probably I'm forgetting some other option. It's going to be an important debate. But my point is going to be why to destroy the sleeve, because the sleeve is good. They're going to be performing 50% of all our patients. It means that something is working properly in those patients. So take advantage of it. We are preserving, some secretion like chloric acid, pepsin, gastrin, digestive factor. There is no biliary reflux. We maintain the pylorus, and we are improving the absorption of some substances. This is our experience, regarding examining, exploring the role of SADIs as a second step after a weight loss operation. This is our first paper in 2014, in our 18 patient, this is our experience. We are now recently updated in 2020, our 51 patient followed 5 years after the procedure. Here you can see, a clip, regarding how we perform this procedure. I mentioned a difference when we are operating or trying to destroy the inverted comma the sleeve. We will have to fight against the adhesion with the sleeve, with the liver, with the previous stapler there. And when we are deciding to perform studies after a sleeve gastrectomy, we are now operating on a free, a non-touch area. Here you can see you have to forget about, the previous sleeve, because there is already, of course, we previously, before making the decision, we explored that performing a CT volumetry. And then, after confirm that the sleeve is appropriate, we are operating in a very, free surgical field. There is no adhesion, so the dissection of the duodenum is going to be very nicely. Here you can see the pancreas, the duodeno-pancreatic circles. Here you can see gastroduodenal artery there. You don't have to take care of that. You can go this way. This is the pancreas over here, and then we have to find some room. Here you can see the pancreas. This is our limit. The gastroduodenal artery is over there, and so you are operating in a very nice way. for the sake of time, you are passing, you know, a vessel loop or a tape there. We divided, you know, the duodenum in a very nice way. We don't use reinforcement in this section. And then after completing, you know, this transection, we go down, you know, in terms of having here, you can see the proximal duodenum, the duodenal stump over there, and we put the stitch. We use the 3-0 bar-based suture for avoiding, you know, to be confused to the torsion of the proximal duodenum, and then we go downwards. We identify the ileocecal valve. We count, you know, depending on the case, 250 or 300, and then we bring up the loop. And here you can see how we perform, you know, very tension-free duodeno-ileostomy. We perform the anastomosis in 2 layers using bar-based suture, you know, the 2 posterior layers and one anterior layer, and then we finish putting some interrupted. This is here you can see when we open, you know, the duodenum and the ileum, and we perform a tension-free anastomosis without very nice, you know, putting 2 ends of the bowel together, the duodenum and the ileum. And then, you know, after that, we perform, you know, an anterior. This is we are performing now the anterior layer, again with the bar-based suture, 3-0 running suture, the 3 first layer, and then we perform some interrupted stitching with TPSTO. Of course, we can do, you know, this anastomosis, you know, stapled anastomosis using a 45 millimeter cartridge or 30 millimeter cartridge, depending on the stapler you're using. Going to be another option of performing this kind of anastomosis. But again, I'd like to highlight how, you know, we are operating in this non-previously touched area. Going to be much more easier. As I mentioned, you know, in 2020, we updated our result. We put it in SOAR. Here you can see, you know, the result. 5 years follow-up of our patient after the sleep. The patient did well, then worse, and then after SADI procedure, maintaining a very nice set weight loss over 75%, a very nice total weight loss around 38%, a very nice BMI numbers. And here you can see when we go deeper in our result, those patients did better. Was those patients initially with BMI less than 50. Those patients that were operated later than 3 years, and those patients that, you know, that had a better result after the previous sleeve in the first operation. And when we studied, there is a direct relationship between a better weight loss after the sleeve and a better weight loss after study. This is a linear correlation between the 2 issues. And those figures have been reproduced by Dan Cotton in the US, in Utah. You know, here you can see mimicking results that ours in this paper. I'm going to be to comment, you know, a very important paper coming from the Netherlands. You know, in this very nice study, you know, they compare, you know, a patient after failing a sleeve, you know, submitted to Roux-en-Y gastric bypass, you know, these numbers, and after performance studies, 250 from the ileocecal valve. You know, have to reinforce, you know, the patient compared to from a sleeve to studies, you know, the common channel was 250, and when they were performed a Roux-en-Y, the biliopancreatic lead was 150. You know, a very important point, you know, to highlight. So in the end, 5 years after this study, you know, the patient submitted to studies, they had the benefit of 26%, but only 7% the patient submitted to Roux-en-Y gastric bypass. Here you can see, you know, that here, you know, going to be almost the same total weight loss that before being submitted to the Roux-en-Y gastric bypass. Again, going to you know, to underline that going to be a biliopancreatic of 150. So, and in this study, you know, the differential regarding nutritional deficiency, there is no differences between Roux-en-Y and SADIC procedure. Again, Roux-en-Y, biliopancreatic lead 150, SADIC procedure 250, the common channel. You know, there is no difference. Even better, you know, vitamin B12, of course, in SADIC procedure compared to the Roux-en-Y gastric bypass. And here you can see, you know, the demographic, you know, display of this study. 141 patients submitted, 66 to studies, 78 to Roux-en-Y gastric bypass, the majority to insufficient weight loss, some functional problem, you know, I mean, GERD mainly, when the sleep failed, they have to submit to Roux-en-Y gastric bypass. But here you can see being no differences in quality of life, complication, and micronutrient deficiency study results in more than double the amount of weight loss. In conclusion, the conversion of sleep to studies is to significantly more total weight loss compared to Roux-en-Y gastric bypass, with no difference regarding quality of life, complication rate, or micronutrient deficiency. When GERD is present, of course, as I mentioned previously, Roux-en-Y is the ideal option. We also compare, you know, the role of studies in this scenario with one anastomosis gastric bypass. This is a study we performed, including 42 patients in the study and 42 patients one anastomosis gastric bypass. We performed this study with our colleague from Germany. And then here you can see 3-year result, a little better regarding total weight loss favoring studies, but no significant differences. A little bit better studies in say weight loss, but no significant difference. But the most important landmark was regarding the adverse events. Going to be a higher incidence of symptomatic viral flush, 26% compared with 4.8% with the SADIC procedure. So it's going to be in this session. So in summary, when we are to think about the therapeutic option of weight regain and insufficient weight loss after a sleeve gastrectomy, for insufficient weight loss due to gastric dilation or not very well performed sleeve, of course, we can think in performing sleeve, but or Roux-en-Y gastric bypass. But we are dealing with insufficient weight loss without significant abnormality of the sleeve. I think the studies got the higher consensus agreement, 88.5%. Then one anastomosis gastric bypass was also proposed, BPDDS 81%. Roux-en-Y was not considered in this option regarding, but the other alternative was much better than Roux-en-Y gastric bypass for insufficient weight loss. So I think, you know, in this sense, you know, as a second step, studies of revisional procedure after leave going to be a very important protagonist, a very important role. What about after? Of course, we can perform studies after gastric banding, after vertical banding gastroplasty. We have a pairing in all these issues. What about after gastric bypass? There are some experiences, you know, this is the pairing of Alberto Teixeira and Muhammad Javad, you know, in this paper published in Surgical Endoscopy, 15 patients, 10 submitted studies, 5 to BPDDS, follow-up 2 years, 2 weeks. This is the numbers. You know, here you total weight loss, very nice weight loss, 2 years, 25% of the weight loss converting Roux-en-Y to SADIC procedure. And when we perform some questionnaire in Barioli, in this forum of, you know, some expert commenting, you know, when we convert a failed Roux-en-Y gastric SADIC procedure, you know, finally, you know, the majority of people, you know, voted for performing a SADIC procedure against not distalization, not pause resuscitation, no reanastomosis, the Roux-en-Y gastric bypass. Probably the best alternative would be the studies, even we have to operate the patient. As I mentioned, we have to try to put the patient under multidisciplinary team anyway. And then this is our experience. We are operating 18 patients after Roux-en-Y gastric bypass submitted to study, 14 for weight regain, and 4 for recurrence comorbidity, mainly hypertension and type 2 diabetes. And here you see a short clip, you know, just to show you how to convert a SADIC procedure, a Roux-en-Y gastric bypass in a SADIC procedure. Let me silence, you know, this clip, you know, and here you can see the way of we do that. We are dissecting, you know, the remnant for the pouch, and then second time we are to going faster, and we divide, we identify the pouch, and we go down in terms of performing, you know, the remnant, and then we perform, you know, this is the pouch, the previous pouch, this is the remnant. We open up the pouch and the remanent. We, in this case, we put a stapler anastomosis between the remanent and the pouch. We can do also hands-on, and we close the defect with a 2-layer, with valve filter 3.0, and then, you know, with another couple of layers in this issue. And then after that, we check, you know, everything, and we check, you know, the ruling. If the ruling is shorter than 1 meter, we remove that. If not, you know, we can maintain, you know, the anatomy reanastomosis. In this case, we are dividing, you know, the anastomosis, and then we are performing the pseudo sleeve. In this case, we are endoscope, you know, inside checking, you know, the stanquity of this gastrostomy, and then, you know, there is no leak over there. Then, you know, we go down, you know, we divide the duodenum over here, and then we go to the ileocecal valve. We identify the ileum. We damp, you know, the ileum 250 or 300, depending, and we perform again anastomosis that you saw previously between the proximal duodenum and the distal ileum. You know, it's going to be, of course, you know, a challenging operation, but it can be performed in this way. We have the opening of the duodenum, the opening of the ileum, and we perform, as I mentioned previously, you know, 2-layer anastomosis between the two ends of the procedure. And in the end, when we finish, we again, you perform a stanquity test with methylene blue. This is the pyro here, the duodenum here is the end of the duodenum. Ileal anastomosis performed 250 or 300 centimeters. They're going to be the final shape of the procedure. And then, you know, we have another alternative. We already published in Western Society this year, you know, how we, the different options. We can do a 2-stage. We can do first stage and do, you know, dismantle the Roux-en-Y gastric bypass plus sleeve, and a second stage to do the anastomosis, the other part of the study procedure, or you can do another option. 2-stage, first stage, you know, undo the Roux-en-Y, duodenoileal anastomosis, and the second stage, when this anastomosis is going to be the most challenging, we can do the sleeve if the patient is not doing well. I think going to be the most important. There are several options in terms of dealing with this so challenging situation that are going to deal with a failed Roux-en-Y gastric bypass, and which is the role of the SADIs in this situation. We also have the possibility of using SADIs after banding. There is some Chinese experience in doing that. You know, they published 22 patients who previously underwent laparoscopic adjustable gastric banding. They received a SADI procedure, a revision study with a very nice result. So, in conclusion, the SADIs as a revisional procedure makes sense because it's a modification of a very well-known procedure, duodenal switch. It just is one anastomosis duodenal switch. We have several positive factor. We preserve the sleeve gastrectomy. We preserve the antropyloric anatomy. We don't have any antrum retained. Any retained antrum. We don't need to perform a Roux-en-Y reconstruction. We don't need to close any mesenteric defect. And that's all I'd like to share with you guys. I'm more than open to answer any question, any comment from you guys. Thank you very much again. I'm stopping sharing my screen.
Thank you very much, Dr. Torres. Quite a comprehensive presentation full of data and knowledge. Abdurrahman.
Yeah, thank you, Safwan. So, Professor Torres, really a excellent presentation as usual. I have two questions. The first one is about the measurement of the common channel, and when do you do it 250, when do you do it 300? And the second question is about conversion Roux-en-Y to SADI. So at the ASMBS meeting in Dallas, a group looked at all the patients that were done in the US, not a large number of patients, maybe 170 patients, and compared them to patients who had distalization. And the group that was converted from Roux-en-Y to SADI had 8% leak rate, 30% complication, 8% leak rate. So my question is, when you do the second stage where you do the undoing of the Roux-en-Y and the duodenoileostomy, which was presented by Sanchez Pernat also in Dallas. Do you have delayed gastric emptying because there's still stomach before the sleeve?
Well, thank you, Aderman. You know, regarding the first question, when regarding how to, I think you will have to take into account BMI of the patient. I mean, before the sleeve. If the patient was very heavy, very colic with a BMI of 50, those patients would be 250, the ideal distance. On the other hand, the patient is not so heavy, I mean, BMI 40 something, not very metabolic, and you know, you are considering to reoperate the patient due to a weight regain or something like that. I think in those not so heavy and not so metabolic, 300 would be the ideal. Regarding the morbidity, the complication rate, and the leak rate of converting Roux-en-Y in SADIs, you know, this is the reason I propose, you know, one of my last slide to take care of performing first the gastrogastrostomy and not go further if there is some concern regarding the blood supply of this area. In this issue, I think going to be very interesting to use the green indocyanine, you know, the indocyanine, you know, to check if everything is okay. And if you have some doubt, some concern, stop there. You know, don't do the sleeve. It's going to be to increase some blood supply injury there. Do your duodenal and then, you know, do the re-sleeve, you know, the restrictive component of the procedure later on. You know, I think, you know, the most challenging part of the operation compared to Roux-en-Y in SADIs is the gastrogastrostomy, because the dissection to maintain the blood supply of this area is essential. So I think you have to be aware of this so challenging procedure. But in the end, you know, as the time goes by, if we are more, you know, more experience in dealing in having this kind of procedure, I think SADIS procedure will be a very nice alternative, you know, to convert a Roux-en-Y for weight regain or not doing well. But in the end, as you know, I usually say that the most important prevention of this situation is not indicate a Roux-en-Y gastric bypass in not very well indicated patient. I mean, very, very heavy patient and very metabolic patient. Do a sleeve or SADIS at the beginning, but if you don't indicate a Roux-en-Y, because you know the percentage of failure going to be almost 40% long term.
Gentlemen, thank you very much. A very quick question, Professor Torres, before we go to Tom. You talked about that we can do stapled or hand sewn the gastrostomy. Did you do any study to compare the difference? I mean, is it as safe? Is it different, or is your personal impression out of your expertise?
You mean the duodenal, right?
Yep.
Okay, you know, we have experience, you know, at the beginning, we weren't so skillful at the beginning of our experience, you know, early 20s. And so we performed anastomosis in a staple way, you know, using 30 millimeters cartridge. Then, you know, we changed to do hands-on because we found more versatile to do that. But now we are, you know, immersed in a prospective trial comparing a stapler and hands-on. But we didn't have any complication in the last 40 patients. We have 20 in each arm, but we don't have any problem. Now our experience increased, and I don't think going to be to find any experience. But you know, it's just a piece of information for those people that are with a little afraid or scared about performing hands-on. You can do the same. You can put a stitch. You can do 2 holes to introduce. It's going to be advisable not to introduce a 60 millimeter cartridge. It's going to be to introduce 45 or 30, because it'll be more, you know, easily perform the anastomosis in this way. But it's going to be, I don't think going to be any difference, depending on the skillful and the preference of the surgeons.
Thank you very much. Quite informative discussions and presentation, as always, Professor Torres. Now we go to, apparently, Dr. Khalid is still in the OR, didn't hear from him. So we go to the last but not the least speaker today, Professor Thomas Regula. I'd introduced him already, and he's an expert robotic surgeon, and he's going to talk to us about the other approach to revisional bariatric procedures, and we'll talk about his experience in robotic revisional bariatric surgery. Tom.
Thank you, Safan. It's my great pleasure to see you all, my dear friends. We know each other for many, many years. I appreciate all your job and teaching that you provide for the community, and learn a lot from all of you. Thank you again. And also I want to thank you, Easy Search, for sponsoring. We know each other very well. Great products, IBC using a lot of those products, and I appreciate your help and support. 1 second. So just to clarify, because I'm confusing a lot of people, my academic appointment is still in America. I'm at Case Western in Cleveland, but clinically I work mostly here in Kraków, Poland, and I work at the university and mostly in private practice. My disclosure is I'm very involved in practically any robotic companies. I'm a paid proctor for Intuitive Surgical, but also for new companies called GMR, and also for Transenteric. So I use all of the existing robots pretty much on daily basis, and I have pretty much good sense on how they work. So a little bit of the background. As you know, sleeve gastrectomy is the king or the queen of bariatric surgery. Pretty much everywhere in the world, it's more than half procedures globally is a sleeve. Depending on where we are working, in America, it's half and half bypass and sleeve. I'm not sure if it's like this still or not, but Europe, especially Eastern Europe, where I am now, is mostly sleeve. Western is probably half and half. Asia is more and more sleeves, and Middle East, that might be wrong, but I think sleeve also dominates. So anyways, we will have thousands of patients of sleeves. Some of them will be very successful. Some will need some sort of revisions. Just to remind you an obvious fact that Michel Gagné invented sleeve as a stage procedure. Actually, I was his research fellow in early 2000s when he kind of accidentally discovered that sleeve alone was fine at some point when the patient was too risky to do, and then he added second stage gastric bypass later on. So the initial thought was that sleeve is a stage procedure. So an interesting summary was provided recently by EFSO to look at early results of sleeve depending on patients' initial BMI. It sounds like for majority of patients, it's okay for first year, except of extreme weights, extreme BMIs, very high patients, very high BMI patients. Even in the short term, they seems to be doing better with sleeve, with gastric bypass as the first procedure. Same with long-term outcomes in high BMI. This is the summary from my previous work at the UPMC in Pittsburgh, when we look at 8 years follow-up in very high BMI. So they are quite okay in terms of actual weight loss for the beginning. And then 7, 8 years after the procedure, the BMI is kind of getting back. This is the long-term study published recently. It's a 15 years follow-up gastric bypass, sleeve gastrectomy with pretty good results in terms of weight loss. But this was at the cost of quite significant conversion rate. About half of those patients, they need to be converted. Half of those conversions were due to weight regain, and another almost half because the reflux. So it sounds like we need to be prepared for a large wave of revisions after sleeve. How about diabetes? This is our own famous STEMPE trial, which we did in Pittsburgh, in Cleveland with field shower sleeve patients. After 5 years, they're doing okay, but there is some tendency of, I wouldn't say failure, but less than expected outcomes of type 2 diabetes. Our home, which is American Society of American College of Surgeons, provides an excellent tool, a bariatric risk calculator, which I use on daily basis practically, especially when I talk to the patient. I provide them very detailed calculations to compare bypass versus sleeve. And that helps me a lot with conversation, which operation should be better. It is a short-term 1 year kind of prediction, but it helps me a lot to tell the patient which operation might actually be better, especially in terms of complications and outcomes, weight loss and risks. ASMBS has its statement position in 2017, which pretty much covers what I previously said, that initial weight loss for both procedures can be similar. However, reflux is a problem after sleeve. It might be acceptable primary procedure for some patients, but we need to be prepared for revisions. And I'm very glad to see and congratulate Antonio that ANZMS endorsed SADI as probably the only procedure at the time being from those new procedures. I'm very close to do SADIs, Antonio. I'm a little hesitant. I need to learn from you, but I think that's a good option, really. That summary, the recent study shows that basically any revisions after sleeve work. SADI is good. Mini gastric bypass is good. It needs to be learned, and I'm not good at this. I don't do this. I still stick with gastric bypass as my primary choice in terms of revising sleeves, with some modifications in terms of length of BPD. This is what we heard earlier today. So I will show you some cases that I did myself in both my practices in America and here in Poland. The advantage of using robot is there are multiple advantages. There is one very important for the institutions, that this is a very strong marketing tool. Our private hospital, which I work right now, has a significant financial benefit. And I'm very honest with you, we earn quite a lot of money by using a robot every day on different procedures, also for bariatrics. It is attractive for patients. They keep asking me, doctor, I know it's very expensive. I don't care. I just want this operation to be done by the robot. From surgeon's perspective, the benefits are few. It is more precise, it's true, but it's more predictable. You can repeat the same way every time, and it helps you being very consistent. It definitely helps ergonomics and improve quality of your life, because you're sitting for sometimes many hours in those revisional cases. The visualization is excellent, not only because it's three-dimensional, but it's very stable. I'm not reliant on my shaking residence. It's extremely steady view. If it reduces invasiveness, I don't know. I honestly don't think it's that less invasive. It is still quite invasive, as much as laparoscopic version. So these are the reasons why I like using robot to revise sleeves. First, it's very consistent. I can repeat my technique in great details every single time. Now, very, very important reason, and I think that's the number one reason, is I prefer hand-sewn anastomosis on any procedures, even primary, but on revising sleeves, as you know very well, we deal with thick stomach wall and sometimes quite narrow sleeve, especially at the base. because I prefer to anastomosis at the base of the sleeve, and sometimes there's not enough space to do the anastomosis. So in these difficult locations, hands-on anastomosis is really easier to be done with the robot. I will show you some videos later. Now, third very important reason is we do and we see more and more hiatal hernias and moving the sleeves into the mediastinum. You probably heard, you know those cases very well, how horribly difficult is to dissect the hiatus around the sleeve that has been sucked into the mediastinum. So I found robot really helpful in dissecting the hiatus around that sleeve. Finally, in high BMI patients with thick abdominal wall, I don't really need to hold that heavy abdominal wall on my hands. It is kind of helpful as well. This is the reason which I don't like robot for my revisions. First, it's crazy expensive. You need to be careful on every single instrument that you pull out from the storage because it costs a lot of money. Single use, it's a lot of money to be used. And sometimes those costs, they don't really justify benefits. The setup and access to the patient sometimes is extremely challenging. It takes sometimes 45 minutes or half an hour to make a proper setup. The exposure to the very upper stomach, I'm talking about hiatus, requires putting the patient in a steep reverse turn Delagour position. Some types of robots are very difficult to set in this position. Plus, you need to sometimes redock the robot, put the patient into the proper position and dock it again. Really, really annoying at some point. You cannot do things in the different quadrants of the abdomen. That sometimes requires redocking. New robots, X and XI, they have the better ability to do it, but it's still challenging. Staplers are currently available for the robot. They are much more expensive than laparoscopic ones. So far, we had only 45 millimeter staplers. Now I think they have 60, and they are still quite difficult to place, especially in a very high part of the sleeve for revising the fundus. We saw earlier videos of re-sleeving the sleeves or resizing. With the robotic stapler, it is possible, but it's kind of difficult. So my experience comes from primary gastric bypasses, which I did robotically all the time. When I was at the Cleveland Clinic, we did about 500 cases of the robotic gastric bypasses. And the conclusion was, based on the study from that experience, it's not better. It's at least the same in terms of leak rate, complications, and outcomes, is as good as laparoscopic ones. It takes more time and it's much more expensive. So the outcomes were quite the same. We did some revisions, but that study was in regards to primary gastric bypass. It is convenient, no question about, but you still rely on sometimes laparoscopic portion, which is retraction or putting staplers. So you need to have a very good fellow to do this in a safe fashion. Some conclusions, even my own, emphasize one particular portion of the robotic procedure, which is hands-on anastomosis. That study comes from the kind of pioneers of robotic gastric bypasses, and the first conclusion was it really helps constructing hands-on anastomosis. So if you prefer EEA, makes no sense to do the robotic. If you like a hands-on, yes, robot is a nice thing to do. It helps with two things. First, in my experience, and this meta-analysis, it significantly decreases incidence of bleeding from the anastomosis. Quite common problem with the EEA, and also in our experience from Cleveland Clinic, it decreases a stricture rate. But as we concluded from another study, which I was part of at the Cleveland Clinic, the robotic surgery has the greatest impact on increasing the cost of treatment. That's no question about. These are a couple of my cases from my experience. This is the case of a patient who underwent sleeve gastrectomy 3 years prior to the revision. She came to us to Cleveland Clinic suffering from significant reflux. She basically could not swallow any solid foods. She was mostly on liquid diet all the time. Let me start this. Despite of multiple attempts of endoscopic dilatation of the narrowing at the distal stomach, we couldn't achieve removing of her reflux. So there was a narrowing of the sleeve as the primary reason. You will see this in a minute. This is her original operation. It was done according to the rules, appropriate bougie. The hiatus was closed. There was no hiatal hernia, and no hiatal hernia was also found in the surgical studies. She did have a stenosis, which was easy to find on endoscopy. The contrast study was showing significant narrowing, you can see it here, of kind of mid of the stomach with dilatation of the proximal stomach. This is a typical robotic setup. Those days we use SI, the older system, which is a little bit bigger than the current one, but principles are the same. So the setup is, we start from the sleeve. First, we identified using intraoperative gastroscopy, the actual narrowing. Then we transect the sleeve gastrectomy above the narrowing. I did not do resizing of the sleeve, and that could be controversial, I think, because the pouch was quite large. And then we did a standard Roux-en-Y gastric bypass with 50 centimeters of BP and 150 of the Roux limb. And that part is primarily done like laparoscopically, except of closing of the enterotomies, which we do hands-on with the robot. We found it quite easily. Now, measuring of the intestines, this is what we heard earlier, very important and quite difficult robotically at the beginning because you don't have tactile feeling. You can rip the intestine very easily, so you need to be very, very careful. Now, stapling part is still relying basically on laparoscopic approach. However, we have robotic staplers available, quite difficult to use sometimes. Now, any hands-on closure, it's super easy. And that I have to tell you, whenever you need to stitch, maybe Antonio will confirm with his studies, a robot is a dream thing to do. Even with no experience at all, from day one, you can stitch like crazy. It really feels like you hold the needle in your fingers and you stitch with your own fingers. Beautiful, elegant, nice, and you can do the stitching pretty much anywhere. This is the gastrojejunal anastomosis between the pouch which was left after transecting across the sleeve. And I want to pay your attention here because the stomach wall in sleeve likes to be quite thick. And I sometimes have problems getting the right layer, but a robot helps me because I can see every layer separately, and with great magnification and quality of view, I can take layer by layer the stomach wall and reconstruct hands-on anastomosis very nicely. Now, you see some bleeding here that also can be easily controlled with the robotic stitching. At the beginning, I use a lot of endoscopy, like you see here, to make sure I'm not going intramurally. It's very easy to make that mistake, especially when you're in your early robotic experience, when you don't really see the lumen very well of the sleeve because it's kind of collapsed. So I use endoscopy to mark out where the lumen is, and I leave endoscope inside to make sure I'm not narrowing. I do 2.5 centimeters anastomosis, pretty much like what I do with normal gastric bypass. And now, stitching is also easy because I use left and right hand. This is the final result. The patient did very well. Reflux improved significantly. I am not sure if I did correct operation by not resizing the sleeve in her case, but she clinically did okay. Now, second video, and even more important. This is a terrible case of retraction of the sleeve into the mediastinum because of the hiatal hernia, which was kind of left without repairing originally. Nightmare, absolute nightmare to do this because the edge of the sleeve, the staple line of the sleeve, stacks into the left crura, and it's super difficult to do it laparoscopically. Now, a robot has a lot of interesting tools. So this is a monopolar scissors. All of those instruments are articulating. So I can use any angle, and I can go into the mediastinum with my three-dimensional view and explore very carefully the esophagus to make sure I have enough length of diaphragmatic esophagus to maintain the anti-reflux rules. It is still difficult, but it gives me one important thing: stability of the view and incredible quality of the, you know, obviously you see on that video, which is not a good quality, but in real life, robotically, you can go physically into the mediastinum and take fiber by fiber separately, including the vagal nerve, which you see very, very well. I use ICG. Some of you mentioned about ICG, not to see blood supply only, but I also see anatomy. I can differentiate between the vagus nerve, which you can see here, it's more white. I can also see layers of the esophagus, and I can kind of separate that from the edge of the stomach. So I can find I would say routine cases like gastric bypasses or mini gastric bypasses. For revisions, it is kind of cumbersome. It takes time. You end up, I mean, the way you feel, it's kind of uncertainty what you are doing at the beginning, because first of all, there's no haptic for feedback. You don't feel what you're doing. Second, you are working in a very narrow operating field. It's about 10 centimeters of the operating field, and you don't know what's around you. You don't, because we used to have that, you know, wide look around. In the robot, you are very narrow. So you really need to have a very good plan to go in and do what you plan, rather than thinking and developing things while you're doing this. So it has certain limitations that some people are not aware of. So it's not a perfect solution. And I don't agree with many hospitals, including my own. Actually, they pay me quite a lot, but it's not. They call it a future of surgery. I think in some areas, yes, it's good improvement, but I don't agree it's a future. It will not replace what we are doing now. I'm a big fan of robotics. This is what I'm doing all my life, but I have a huge respect to these procedures and to this technique.
Let me have a couple of comments, Professor Safwan, regarding Thomas, presentation. I think I completely agree with him regarding, because the role of robotic in revisional surgery, because revisional are plenty of non-expected situation, so I think robotic, as he mentioned, you have to focus to be very well planned, or to perform the surgery. So my advice would be that him, if you are not sure what you are going to find in the reoperation field, I think you're going to be better starting, performing standard laparoscopy and having a wider view of your surgical field. I completely agree with Tom regarding this approach. It is very, very important, because sometimes some people give the opposite message. As this is revisional, robotic is safer. I don't agree. I agree with Tom comment. They're going to be very important message to take home this kind of advice. Thanks.
I really appreciate, Antonio. This is very important that we both speak the same language. I tell you more, all my problems that I had was from the revisions robotic surgery. I went into this without that respect that you mentioned. Very, very, very important.
Thank you, gentlemen. One thing before we go, our Chinese spectators or audience, many of them asked repeatedly one question. I'll leave it to Abu Ali, Abdulrahman to summarize it very quickly. We have very short time. They say, in summary, what are the guidelines of the best way of revising sleeve? Which procedure for which sleeve?
Sure. So I think one of the important things is, does the patient have reflux? And if they have reflux, you need to do objective testing. Endoscopy is not enough. You need to do a Bravo study and sometimes do impedance to look for bile reflux. If the patient has objective evidence of reflux or Barrett's, the procedure to do is Roux-en-Y gastric bypass. If the patient does not have reflux and the main purpose for the surgery is weight loss, depends on your experience as a surgeon. If you are an experienced surgeon, I think SADE is the best option, in my opinion. If you are uncomfortable dissecting the duodenum, which needs some training, I think one anastomosis gastric bypass is reasonable, granted you do 4 things. You make a long pouch, you close Peterson space, you measure the common channel at the end of surgery, and you follow the patient with endoscopy.
And a long pouch, you mean around 360 millimeter staples, not beyond 20 centimeters.
So at least down to the cross foot.
Yep. Thank you very much, Abu Ali. Thanks a lot. Gentlemen, we come to the end of our excellent webinar. It's almost 2 hours, but honestly, I didn't really feel the time. Thank you very much for sharing your expertise with us, for your time. Hopefully, I look forward to meeting with you all in person soon and in other webinars. Thanks again to EasySurge for their generous support that made this webinar possible. And that's it. Thank you very much. Have a good day or good night, wherever you are. Thank you.
Thank you.
It's been a pleasure. Thank you.
Ali, take care. Abdurrahman, see you very soon, guys.
Ma'as salam.
Have a nice day.
Nice day, Antonio.
Bye, Ali.